So I would like to present our local experience at Ibn Sina Hospital in management of patients with refractory epilepsy at the Epilepsy Monitoring Unit. First, I would like to give a brief preview on epilepsy and seizures in general, and then to talk about refractory epilepsy and the role of diagnostic tools in working up patients with refractory epilepsy, and then I'll shed some light on some patients that we have evaluated at the Epilepsy Monitoring Unit at Ibn Sina Hospital. So to start with, the seizures are the clinical manifestations of an abnormal excessive excitation and synchronization of a population of cortical neurons. While epilepsy, it's a condition or it's a disorder characterized by recurrent, which are 2 or more epileptic seizures which are unprovoked by any immediate identified cause. And by provocation we mean like acute metabolic derangements like hypoglycemia, hyperglycemia, or in the settings of an acute stroke. So the epidemiology of seizures and epilepsy, the incidence of seizures is 80 per 100,000 per year as per international statistics, and 1/3 of those seizures are febrile convulsions, which we usually don't consider as epilepsy. While epilepsy, the incidence is 45 per 100,000 with a point prevalence of 0.5 to 1%, and the cumulative lifetime incidence of 3%. So as we can see that epilepsy is a common disorder. Now the incidence of epilepsy in the general population, it has a bimodal distribution. So as you can see, patients who are less than 20 years are more likely to get epilepsy de novo, while patients more than 60 years also have more chance of becoming epileptic, and the causes differs in patients who are less than 20 and in patients who are more than 60. So in patients who are more than 60 years, the etiology mainly are tumors and post-stroke, while in patients who are less than 20 years, the etiology usually is genetic predisposition and idiopathic. The causes of epilepsy, most of the causes of epilepsy are unknown. So we have 68% who are idiopathic with no known cause, and then the rest are CNS infection 3%, brain tumor 4%, trauma 4%, developmental 5%, cerebrovascular disease like strokes 11%, and others. Regarding the mechanism of seizures, well, in the brain we have 2 systems that work in equilibrium, which are the excitatory and the inhibitory system. So patients who have epilepsy have either too much of an excitation or too little of an inhibition, and the excitation is usually secondary to overexcitation of the sodium and the calcium channels, or an excessive of the excitatory neurotransmitters, and the most potent are the glutamate and the aspartate. While too less inhibition could be either secondary to dysfunction of the chloride and the potassium outward, or chloride inward and the potassium outward currents, and either it could be too little to the inhibitory neurotransmitter, which is most potent, the GABA. We classify seizures and epilepsy into partial and generalized, and this depends on the focus of the generation of the epileptic activity. So if it is in one part of the brain, we call it partial, while if it starts in the entire brain, we call it generalized. And we have different types of seizures in the partial epilepsy: simple partial seizures, complex partial, and secondary generalized seizures. In the simple partial seizures, the patients have intact level of awareness. In the complex partial, they have impaired awareness, and in secondarily generalized seizures, they have tonic-clonic seizures that are preceded by partial symptoms. While in the generalized, we have different types of seizures, which are mainly the absence, myoclonic seizures, atonic, tonic, and tonic-clonic seizures. And now, what is the natural history of epilepsy? What happens to patients that we diagnose early as newly diagnosed epilepsy? So, most of the patients, which are approximately 60%, have remission, either with treatment or spontaneous remission. Spontaneous remission usually are patients who have childhood absence seizures and benign Rolandic epilepsy, and other patients that require treatment may respond to only one anti-epileptic medications. While on the other hand, 30 to 40% will continue to have seizures. And in the next slide, we'll show, this was published by Kwan and Brody. We can see that newly diagnosed epilepsy patients, 47% of those patients will respond to the first anti-epileptic and will become seizure-free. Now, if those patients do not respond to the first anti-epileptic, if we'll shift them to another anti-epileptic, then they'll only have a 13% chance seizure of becoming seizure-free. And the rest, which are 40%, will be put in the category of difficult to treat epilepsy patients. And those patients usually will require either surgical assessment, or they will require dual or 3 anti-epileptic medications or more to control the seizures. And according to the International League Against Epilepsy, they define drug-resistant epilepsy as failure of adequate trials of 2 or more tolerated, appropriately chosen and used anti-epileptic medications to achieve sustained seizure freedom. And the chance, or among patients who failed to respond to 2 appropriate anti-epileptics, if we give a combination of the anti-epileptics, or if we add, or if we shift them to a third anti-epileptic, then the chance is only 5 to 10% to achieve seizure control, and this is a very low number. So what shall we do to those patients? We shall work them up as pre-surgical candidates, and usually we have to search for the other ways in order to render those patients seizure free. And the most effective way that will render those patients seizure free is the epilepsy surgery. While there are some other palliative methods that will decrease the amount and the severity of the seizures, and one of them is the vagal nerve stimulation. And the vagal nerve stimulation mainly is a battery that is inserted under the skin, and it has a direct contact with the vagus nerve, which sends impulses to some nuclei in the brain and to the cortex in order to increase the process of inhibition. Now, one of the key elements in the workup of patients with refractory epilepsy is to admit to the epilepsy monitoring unit. So what is the epilepsy monitoring unit? It's a computer and electronically assisted and based unit where routine awake and asleep EEGs, as well as continuous long-term video EEG monitoring, are used, and the main elements, or the main the main aims of this monitoring unit is to diagnose epilepsy, to classify epilepsy, and to choose which patients will be surgical candidates. The EMU at Ibn Sina Hospital is a newly established unit that we started effectively working there at the end of November, and it's a 4-bed unit, 2 male and 2 female rooms, with the control room located in the female section, in addition to the reading station, which is in the doctor's office. Now, since late November, we had the chance to evaluate a large number of patients, which was 114 patients, Most of them underwent long-term EEG, which was 3 to 6 hours. The others remained for more than 3 to 7 days, and we waited for a seizure to happen, and we tried to localize the source of the seizures. Now, what is the role of nuclear imaging in the pre-surgical evaluation? Mainly, the nuclear imaging role is to try to identify what is known as the epileptogenic zone. The epileptogenic zone is defined as the cortical region of the brain that when removed, which is the minimal amount of brain tissue when removed, that will make the patient seizure free. Now, what to do in such patients? We should do what is known as ictal SPECT. And ictal SPECT, we usually inject those patients within 20 seconds of the clinical or electrographic onset of the seizure with a radioactive material, which is mainly the technetium. Okay, so we use either the extended release HMPO, or we use the Neurolite, and in such cases we will identify the epileptogenic zone ictally, and we will compare it to an interictal or in-between seizure image. Now, if we compare this visually, the yield is much less than when we compare it using a computerized system, which will do the subtraction technique and the superimposition over the MRI images. And this is usually done with the help of a computer-based software. So, as already said, when the injection is less than 20 seconds of the clinical or electrographic onset, then the yield is very high. Now, also there is another method in nuclear imaging, which is the PET. And PET usually localizes the functional deficit zone. Now, the functional deficit zone doesn't always correlate with the epileptogenic zone. And I'll give you an example. Some patients with mesial temporal sclerosis have an epileptogenic zone that is usually the head or the body of the hippocampus. But let's say if a patient has a right mesial temporal sclerosis and you do PET scan in those patients, then you may see a decreased uptake or decreased metabolism in the entire right temporal area, and it will not give you a localized decreased uptake from the hippocampus. Also, part of the pre-surgical workup is using the MRIs, and not any MRI. We have to ask for what is known as the epilepsy protocol MRI, which contains specific sequences that are requested specifically for patients who have epilepsy. So I'll start with the cases now, and I'll present the first case. This case was worked up in Ibn Sina Hospital in collaboration with the American University of Beirut Medical Center. So she's a 14-year-old female with history of refractory epilepsy. The seizure started in January 2011 and consisted of episodes of staring, unresponsiveness, minimal smiling, and head turn. The current semiology of the seizures consisted of auras, which are the preceding symptoms, characterized by fear, staring, smile, right versive head movement, right hemifacial twitches, and right upper extremity tonic or dystonic posturing. And all of these symptoms will lateralize to the left hemisphere because the symptoms are usually contralateral. The patient had a large amount of seizures, and those were more than 10 seizures per day. She was maintained on 2 anti-epileptic medications when seen, and she was tried on multiple anti-epileptic medications previously. her exam showed some slowing in slow speech, and the family reported deterioration in school performance. Now, when an MRI was done, as you can see, there was an increased signal over the left temporal area, and when done with the T1 with contrast, we can see that there was no contrast uptake, and there was some cystic component inside this area. And here also the coronal flare shows the high signal over the flare imaging. Now, the patient was monitored and she had a large number of seizures. Now, according to the description of the seizure were typical as described by the family, with the aura then followed by the previously described semiology. Now, as we can see from the ictal EEG here, we see that this is all that is in that is odd is left, while the even numbers are right. So as we can see here, the odd numbers, okay, show some rhythmic activity, okay, and all of the seizures had an onset seen over the left temporal area. Now, when they did in Lebanon ictal SPECT, here we show the ictal SPECT with the subtraction technique, will show that there was this area with an increased uptake when done with the SysCom technique, and it corresponded beautifully to the lesion that the patient had. So what happened is that they did something called the WADA test to lateralize the language, and they found that her language was mainly over the left hemisphere. So the patient underwent surgery under intraoperative electrocorticography, and the entire lesion was removed. Post-op, the patient did well, but 5 days after the surgery, this patient started to experience spells that she didn't experience previously. And those spells were characterized by sudden staring and sudden moaning sound, lasting for seconds and then disappearing. And what we did is that we monitored her after she came back from Lebanon at Ibn Sina, and we found now that all of her seizures had an electrographic onset that was over the right hemisphere, and mainly the right frontotemporal area. So here we see spikes that are happening during the seizure, and the blue color is the right, the red color is the left, and we can see this uptake, this increased activity over the right frontotemporal area. When an ictal SPECT was done this time, we can see that there was an increased uptake over the right temporal area, which was clear, while the left temporal, which was excised, showed a decreased uptake. So what we did with the patient, because it was a very complicated case, it was a rare case whereby we haven't seen such cases that will have aggressive seizures just after the surgery from the contralateral hemisphere. There was a possibility of autoimmune etiology. So what we did is that we gave her pulse steroids, and we did all the autoimmune workup, and we waited for the pathology of the brain tissues. And when the pathology came up, they were positive for cortical dysplasia, and no inflammatory cells were seen. So 1 week or 10 days after doing this, the patient stopped having seizures. She was tapered off steroids, and till today's date, the patient is seizure free. And our theory was, in this particular cases, is that she had two epileptogenic foci, one over the left temporal and the other over the right temporal, and those two foci were interrelated. So when we removed one focus over the left temporal, this caused a marked activation of the left temporal, of the right temporal focus, and the patient started having recurrent seizures, and with time this activity abated gradually. So I'll present the second case, who is a 29-year-old male patient with history of seizures that started in year 2000. Most of the patient's seizures happen during the night, nocturnal. He wakes up suddenly, he has incomprehensive speech, followed by repetitive jerky movement of the right lower extremity that look like complex automatisms, followed by confusion. And most of the spells last less than 1 minute. The patient has something called ictal cough or post-ictal cough, whereby he coughs during the seizure or just after the seizure, and this usually lateralized to the non-dominant hemisphere, which in his case was the right hemisphere. According to the patient's family and wife, all of his seizures are stereotypical. He underwent MRI on multiple occasions and all the MRI results were normal. The patient was tried on different combinations of anti-epileptics and they didn't work, so he was having drug-resistant epilepsy. The seizures were 4 to 5 per month, and he was on the current regimen consisting of lacosamide and topiramate. The patient was admitted to our monitoring unit, and total of 14 seizures that were all identical were captured. During the seizure, he had the same description as per previous slides. So he had complex automatisms involving his right lower extremity, followed by dystonic posturing of the left upper and lower extremity and the left side of the face. And as we can see here, as already said, that the red is the left hemisphere, the blue is the right hemisphere, and you can see this nice build up of rhythmic activity or rhythmic spikes seen over the right anterior temporal area, and this gave a nice electrographic onset, and this happened shortly after the clinical manifestations. Now what we did is that we did an ictal SPECT here at Ibn Sina. It was a very fast injection, less than 20 seconds. Now here, as we can see, this is the ictal, and we compare it to the interictal. In the ictal, we'll see that here there is an area of increased uptake seen over the right temporal area when comparing to the left. Unfortunately, the interictal didn't help much, so I'll show you now the ictal, and here we can see this area of increased uptake over the right temporal area. And when we compared it to the PET scan that was done interictally, we can see that there was a decreased uptake over the right temporal area. So if we see here the decreased uptake from the right temporal area, and we compare it to the ictal SPECT showing the increased uptake over the right temporal area, we got our answer that the epileptogenic focus is most probably in this particular area. Now this patient was worked up, and we'll do the step 2 workup by doing invasive monitoring and surgical excision of the epileptogenic zone to render him seizure free. The third case is a 14-year-old female patient with history of cognitive delay seizures since age of 1 week. The parents are first cousins. Now the seizures are typically sudden extension of all extremities followed by sleepiness, and this is what we usually see in patients with tonic seizure. She had also other types of seizures like focal jerking of the upper and lower extremities over the right side, and stirring episodes which were probably atypical absence seizures. Now she had more than 10 seizures per day, And the exam, it showed severe neurocognitive delay. The patient could not recognize her family members, could not speak, could not do complex cognitive commands. The exam showed hypomelanotic patches or macules over the body, sebaceous adenoma, and multiple stereotypias of the hand. The MRI shows multiple tubers, and the diagnosis is for sure tuberous sclerosis. As you can see here in the MRI, you can see over the both temporal areas multiple tubers, also over the frontal area, over the occipital area, over the parietal area. Now, what we did is that we did a monitoring for this patient, and the patient had typical tonic seizure, and this is the signature by EEG. We can see she had high amplitude spike followed by electrodecrement, so flattening of the brain activity with superimposed fast activity, and during this time the patient had the tonic seizure, and this was followed by atypical spike and wave, or and this is seen usually in patients when they develop atypical absence after the tonic seizure. So this patient was clearly non-surgical patient, and she had multiple foci interictally or in between seizures. Now, what we did with this patient is that we inserted a vagus nerve stimulator, and the patient now is doing pretty good in terms of seizures. She is having only one seizure per day, and she's not going that frequent as she did before to the emergency room in order to get rectal Valium. So the quality of life in this patient and in her family improved drastically. Now, patients with tuberous sclerosis may respond sometimes to surgical treatment if they have only one tuber which is active, and in such cases the patients will have only one type of seizures, and this was not our case. And those patients will identify the tuber by doing something called tryptophan PET if it is available. It's not available everywhere, but if it is available, the tryptophan PET will help localize the epileptogenic zone. Now, the last case that I will present in this lecture is a 13-year-old right-handed boy with history of seizures that started at age of 7.5 years. His seizure used to be characterized by facial twitches and increased salivation, or what are known as opercular seizures. The patient also used to have generalized tonic-clonic seizures. All of the seizures happened during the night until 1 year prior to presentation, which were started to happen during the daytime. And I saw him, unfortunately, I saw him very late. He was 13-year-old, and when I saw him, the patient had moderate cognitive delay. He couldn't do simple arithmetics. He used to have daily episodes of tongue numbness, which were simple partial seizures. And 4 months after the start of the seizure, the family noticed a severe, or noticed a cognitive decline at school. An IQ was done in 2010, and it was a very low. He scored very low in the IQ, both verbally and regarding performance. Now, when we did an EEG, the EEG showed very frequent discharges arising from the left and the right hemispheres, and those discharges were highly activated during stage 2 sleep. So here we see EEG showing very frequent spikes arising from the left hemisphere, temporal, frontal, also from the right hemisphere, mid-temporal and frontal, and also here again. So this patient fulfilled the criteria for a diagnosis called continuous spike wave during slow wave sleep, And this type of disorder is an epileptic encephalopathy. It is age-related epileptic encephalopathy, whereby patients have developmental and various type of psychomotor regression in close to temporal concordance with the appearance of EEG pattern, which are usually typical for continuous spike wave during slow wave sleep. The EEG pattern consists of sleep-related activation and diffusion of spike wave, usually during more than 85% of the non-REM sleep, and those patients will respond to steroids. So what I did is that I started this patient on a pulse steroid dose, and I changed his anti-epileptic regimen completely. And what I did is that I repeated the EEG after the treatment, and as you can see, his EEG substantially improved. It normalized. We can see no more spikes during this stage. Unfortunately, the treatment was given late, so the patient, in terms of seizure, he became seizure free, yet there was no drastic improvement in terms of cognition. So if this patient was treated early, when he was 7 years, maybe he wouldn't have reached this point. I have one more case, and she's a 15-year-old right-handed female with history of spells that started at age of 10 years. The spells consist of palpitations followed by difficulty breathing, and she feels that something is moving underneath her skin, and then she starts having generalized trembling. And the spells are usually prolonged. They happen for 15 minutes, and they all used to happen at school. Now, she was on 2 anti-epileptic medications. Her MRI was normal and her EEG was normal, so she was referred to our center. Now, what we did is that we monitored this patient. We admit her for monitoring, and her EEG was completely normal. So a diagnosis of psychogenic non-epileptic seizures was highly on the differential, and what we did is that we induced one of her spells by asking her to hyperventilate, and the patient had a typical spell. The family witnessed this, and during the entire spell the EEG was normal. So what we did in such patient is that we tapered her off the anti-epileptics completely, and we gave her a specific approach in order to try to control the spells, and with time her spells start to decrease, and now she is spell free. And by this I'll finish my presentation, and I would like to thank you.